APCRS in 2014, MM Joshi Overall Best Award in 2009, and Best Video Award. We have young and dynamic Dr. Saurabh Patwardhan from Sangli Miraz, who is the director of Nandadeep Eye Hospital and a PG Institute. He's a head of FACO training and fellowship program and a chief mentor. And for the first time in the world, they have developed a FACO Tips 3D teaching course. He has more than 12 publications and more than 30 chapters in various books and journals. So I think without wasting a time, we'll just go through the topics which we will be covering. Dr. Saurabh Patwardhan is going to tackle on intraoperative PCR. Dr. Saurabh, please. Dr. Suven, since he's I'm just enumerating so that we don't waste time in between. Or should I wait and... Yeah. So you can, Dr. Suven will be speaking. Yeah, Dr. Saurabh will be speaking first.
Good afternoon, everyone, and thank you, Bide sir, for always giving encouragement to youngsters like me. And no, दूसरा वाला, ये दूसरा है. So I'll be speaking about the intraoperative PCR, how to manage it. ये बंद कर देना. मैं करूँ क्या? Yeah. First. Yes. Okay. So I'll be speaking about the intraoperative PCR, how to manage, and what is the thought process behind managing this. It's a not so rare complication, but I would say this is a complication where we can definitely give very good outcome to our patients if you manage it with proper thought process and proper steps. So, first thing to ask ourselves is that if there is a posterior capsule rupture, is it the end of the case? I would say the thought process should be it's a beginning of a new case. So think of it like you have a new case in hand, and how will you do it perfectly so as to give it a perfect outcome. So one thing you should understand, your plan should be always in hand. So don't be confused about the order of things. So the steps have to be done in this order. First step is to remove nucleus pieces if there are any. The second step should be to clear out the vitreous from the anterior chamber, and then the third step should be to remove the cortex. So I will go one by one and the steps which have to be taken in order to remove. So first thing is calm yourself. As I said, think that now you have got a new case in hand. Don't think about the first case where you were expecting nothing to go wrong, but think of a case in hand. So first thing is how to take the nucleus out. So we have two options. Either we can take it out through the scleral tunnel or through the corneal incision. Now through the corneal incision is easier to master if you are not used to SICS surgery. But again, there will be problems such as you have to give very good sutures, and prolonged suture management has to be required to give a good refractive outcome in these cases. But the common mistakes which are done commonly when you are taking out the nucleus from the anterior chamber is that, suppose there is a 3 mm nucleus piece inside or 4 mm nucleus piece inside, you try to make the incision of the same size, like 3 or 4 mm. It doesn't work because the nucleus is a 3-dimensional structure. So always make a point, the incision size should be at least 1.5 times the size of the nucleus piece that you are going to remove. Otherwise, what will happen? There will be a lot of endothelial damage when you're trying to take out this nucleus. Now, this is another method which is used using wire vectis. But if you are using wire vectis, remember, use a sandwich method. That means you have to put it between two instruments. If you try to do it with single-handed, invariably what happens, this piece tends to rub against the endothelium and you have endothelial damage and edema postoperatively. Now, it's easier to enlarge the existing corneal incision by using corneal scissors. Many times what surgeons try to do is they use the same 2.8 keratome and enlarge it. Most of the times it becomes more ragged than you want. So like the earlier ECC days, the corneal scissor works best. If you do it tangentially exactly, you get very good incision structure. Now, in order to remove the nucleus, the most important tip to understand is that always push OVD from the deeper most part of the nucleus. This is, I think, again, I will emphasize in another video. This is the commonly done mistake by surgeons. They try to keep the anterior chamber maintained, because that is the, your instinct. When you are doing cataract surgery, you try to keep on maintaining the chamber, and unfortunately they push more viscoelastic in front of the nucleus, or when they go behind also, they don't reach the posterior most or deeper most part of the nucleus, and then you may have a situation where one of the nucleus piece drops down. When you have enlarged the corneal incision, make sure that you close that incision before you are going ahead with vitrectomy, because then you have a closed chamber. You have much better control on the globe. You don't have collapsing chamber anytime. So that works best. When you are doing scleral incision, sometimes you may not suture if there is no leak. Okay, always make sure, I think in vitrectomy part, we have to make sure that pupillary contour, the contour of the PC rent and anterior capsule is also has to be properly seen. Now, second part I am going to show converting into the scleral SICS tunnel. Okay, first thing, make the patient very comfortable. If you have a complication, just give a posterior subtenon block. It's very easy. First, I think I will just re-show. First, just infiltrate the intranasal area with xylocaine. You can use just xylocaine. There is no need of sensorcaine. And then create. Now I am infiltrating the intranasal area with xylocaine. Give 1 minute. Then open up that space so that patient is comfortable, and then use a blunt cannula. You can use the visco cannula after removing the visco from that. Go behind and just give 1 to 1.5 cc of xylocaine. That's more than enough. Again, wait for a minute, because it takes little time for the xylocaine to act. Don't just start hurriedly. Wait for a minute and then start making the scleral tunnel. Now, if you are well versed with SICS, then you are good to go with this technique, because here there will be some challenges, like there will be a little bit of hypotonia as compared to a routine SICS case, but you are well versed with SICS, you can do it really easily. Okay, avoid the area of initial incision, but if it is not possible, don't worry. Usually the corneal incision do not merge with the scleral incision. And always make a large scleral tunnel. Don't try to be meager in the size of the scleral incision. You can always suture it to reduce the amount of astigmatism, but you want a very traumatic delivery of the nucleus when you have a complication. Like for example, in this particular case, there is almost entire nucleus. So this was the case where there was a hydro rupture, and we have to remove the entire nucleus. Now, best way to remove this nucleus from the back is either use this ball tip chopper and flick it above, or you can use the Tuschinski method, which I have not shown in this video, but that is also very nice technique to use those two Shinskis like chopsticks and just rotate it in front. Again, here the commonest mistake done is pushing the OVD over the nucleus. Here you want to hook and bring the nucleus up, and then use the viscoelastic. Again, the same principle to remove this nucleus from the if in presence of rent is use the, see, just I wanted to show this. Look at the position of the visco cannula here. It is deeper most and posterior most when I start injecting the viscoelastic, and then at the same time you press the posterior scleral tunnel and the nucleus will come out very easily. This avoids nucleus drop as well. Okay, so using visco removal, good scleral tunnel and nice size scleral tunnel, it's very easy, and you have pristine clear cornea next postoperative day with very good vision for the patient. Now moving out to cortex management. Once the nucleus pieces are out, go ahead with cortex management, but always make sure there is no vitreous inside when you are removing the cortex. So first method is to use the vitrectomy probe itself to remove the cortex, where you can toggle between IA cut and cut IA mode. That means when there is vitreous, you shift to cut IA mode. When there is no vitreous, you do IA cut mode and remove that cortex. But there will be some issues for beginners when they are using this vitrectomy probe to remove the cortex, because vitrectomy probe generally has much sharper edges as compared to bimanual IA. So if they tend to go closer to the anterior capsular axis, they may have tears. Like in this case, the anterior capsule got torn. So it might jeopardize the chances of putting the IOL in the sulcus, or it may also cause dialysis if they are not able to control, because vitrectomy probe might be little bit difficult for the youngsters to control. So for beginners, it is better that you just initially maybe clear off the vitreous first, and then you can shift to the second method, which is using the bimanual itself to remove the cortex. Now, one issue in this case is that if you are not done vitrectomy properly, or during the cortex removal, if there is vitreous strand in between, you have to stop, you have to reflux, and then just change your the aspiration probe with the vitrectomy probe and cut that vitreous. Okay. And third important tip is to do cortex aspiration with cortex removal with dry aspiration, where there is just visco. So what happens is that initially when you are not used to vitrectomy and there is no vitreous, there is just anterior hyaloid opening there, sorry, the PC opening, but anterior hyaloid is intact. Whenever you start the irrigation, sometimes the anterior hyaloid opens up and then you have to do the vitrectomy again. So in these cases, the dry aspiration method really helps, where the anterior chamber is maintained much easier as compared to when there is fluid. Only thing you have to do is that you keep on supplementing this 2% HPMC every now and then you can easily remove the entire cortex with lot of time in hand, because you are not worried about the turbulence which may happen when you are using irrigation in the anterior chamber. So this is the third method to remove the cortex after a PC rupture. Okay. Now we'll move on to the IOL placement in sulcus. Of course, we have to place IOL. So easiest way to do is to do IOL placement in the sulcus. Of course, the 3-piece IOL are preferred. Now, one thing, once you migrate, you become better and better, you have to always think of your plan before. This is very important. You should understand whether you are going to do optic capture or not. That's because if you are going to do optic capture, remember that you have to use the same power which you have decided, the emmetropic power. Because if you are not going to do optic capture, you reduce the power by 5%, because ultimately you are trying to give the best refractive outcome to the patient. So simple tip is that. Now for doing good optic capture, the size of CCC should not be more than 5.2, ideally is 4.8, and it should be central. If it is too decentered, just beforehand only decide, I'm not going to do any optic capture. I'm sorry, pause there. Okay. So again, optic capture is to be done, use the same emmetropic IOL power, it will give you the best result. Okay, now this is a technique to show the optic capture being done. Now the commonest problem which may happen during this case, if you try to insert the IOL directly into the sulcus, so avoid that. Always create adequate size of the incision, because this is a hypotenuse globe. If you have made very small incision, you struggle, you will have problems. So enlarge incision little bit, go ahead, put the Sinski under the optic as always, because you have already done a complication. Now you don't want the IOL to drop down into the, you have already vitrectomized also, so vitreous is also liquid, you don't want that. So open up that 3-piece IOL in the anterior chamber itself, and then you can very easily push both the haptics into the sulcus without any complications. Okay, so always avoid the temptation to put the haptics directly into the sulcus when there is a rent. Okay, now to do the optic capture, again the CCC should be well centered. Now you go ahead with the vitrectomy probe, or you can vitrectomy probe and irrigation, remove the vitreous or viscoelastic which is there behind the optic, behind the IOL, and now you have to push this optic through the CCC margin. And the mistake commonly done is you try to push at the center. Don't do that. Push at one end first. So one side is first optic capture is done, and then you go to the second side, and always look for the spindle sign. You can see here there is no spindle, that means optic capture is not complete. Now I pushed it, now you see a nice spindle shaped anterior capsular axis, that means optic capture is complete. But still it is not over. Okay, you have to make sure there is no vitreous left there. And when you finish the case, even if there is little bit of AC collapse during finishing part, the anterior optic capture may get reversed. So always make sure that AC is maintained. If you feel it has reversed, you can again tap down the IOL so that you have a proper optic capture at the end of the procedure. After any vitrectomy procedure, make sure that the incisions are watertight, so you don't have any leakage, because you have already done vitrectomy, you don't want any leakage from the incision, otherwise suture. Now the last part is, can you place the IOL inside the bag, okay, after having a posterior capsular rupture? Now you will say, why do you need to take these kind of risk when you already have 3-piece option available? Now we have other things to do, like you have multifocal EDOF, toric IOLs, which you need to place inside the bag even if there is a PCR. So let's start thinking whether we need to put it and how to put it. Now first thing to realize whether anterior hyaloid is intact or there is vitreous present. If anterior hyaloid is intact, you can just place the IOL nicely in the bag if there is enough support without doing anti-vitrectomy, but make sure there is no vitreous, because This is another common mistake. If there is a vitreous in the anterior chamber, some surgeons, what they do with the visco, they just nudge aside this vitreous and put the IL in the bag. But if you have not done vitrectomy and you have placed the IL in the bag, on table it may appear well centered, but invariably over a period of time it will decenter. So avoid this mistake. Now let's think, what is the exact part of the posterior capsule that is really needed for the stability of IOL. So if you see this central part, if it is absent, it doesn't matter. You can still place nicely the IOL in the bag. Just make sure the haptics are perpendicular to that. So in this case, it's okay. If you have a small peripheral PC which is rupture, which is smaller than optic, you can still place. But if it is a large peripheral rent, larger than the optic size, don't do that, because invariably over a period of time the IOLs will decenter. Another option is in absent PC is to do reverse optic capture. Put the haptics in the bag and capture the optic in the CCC if the CCC is small enough. Okay, so I will just show few cases where the about the choice of IOL. So if you are going for plate haptic or 3-piece IOL, I think if you have not done a posterior capsular axis, avoid these IOLs because they have kind of springy nature and might extend the existing tear. But these other types of IOLs are quite good enough to be placed in the bag. Now if you can do a posterior capsular axis, really it looks very difficult, but if you when you actually do it, you will find that it's much easier than even anterior capsular axis. So once you have a posterior capsular axis done, you know that the posterior capsular margins are quite stable and you can then easily place the IOL in the bag. So even after doing posterior capsular axis, you have to make sure, just watch how I'm doing anti-vitrectomy. Looking at different marks there, you can see the posterior capsular rent. You can see there is an indent, and once I cut it, it becomes rounding. So these are different signs of presence of vitreous in the anterior chamber. So you need not necessarily have triamcinolone all the time. You can see the different indications of presence of vitreous and you can cut the vitreous completely. Again, while placing the IOL in the bag also, use the same principles. That means first open up this IOL in the anterior chamber, keep the Sinskey behind it, and then slowly nudge the IOL inside the bag so as to avoid any further damage to the posterior capsule. And at the end, after you have put the IOL in the bag, of course, if you have done posterior capsular axis, it's much easier to use your bimanual or coaxial. But if there is a posterior capsule which is torn irregularly, what I do is just do passive visco wash. That means just using the irrigating cannula, just remove as much as visco as possible. This avoids sudden deepening of the anterior chamber after you have placed the IOL, and that avoids sudden extension of posterior capsule. Now here the posterior capsule is torn, but anterior hyaloid is intact, and you can see the size of the tear is small. So I can place the IOL in the bag and I can just do passive visco wash and manage the little bit of rise in IOP. Now how to check whether anterior hyaloid is intact or not? Okay, so once the you can see the posterior capsule opening is there. Once you put visco in it, if you don't see any visco going inside the vitreous cavity, you know that the anterior hyaloid is intact and you can take a decision accordingly. Okay, thank you, sir. I think I completed.
Thank you, Dr. Saurabh, for an excellent video presentation on PCR. We have our next speaker, Dr. Suven Bhattacharjee, who is an innovator and inventor of B-Hex ring, and he's going to talk on how to handle small pupil and IFIS. Over to you, Suven. And the time is 15 minutes.
Okay, good.
After Dr. Suven, we have Dr. Suvira. Okay, yeah, fine. And then Dr. Deepak, and then myself. Yeah, okay.
Okay, thank you, Dr. Santosh.
Dr. Saurabh, please join afterwards for a question and answer session. Thank you.
So I'll be speaking on small people and IFIS. It's all about anticipation, identification, and management. I'm Suven Bhattacharjee, and I do have a financial interest in the BX People Expander and mid-invent devices whenever I speak of it. And let me just see. I would recommend all of you look at this particular monitor because that's not good enough. So why is small people such a big problem? The simple reason is if your pupil size drops down by half, your viewing area drops down by quarter, drops down to a quarter rather. So you have a huge limitation and that could lead to disastrous complication. Again, there's a common notion that this works better, that works better. Let me tell you, nothing works in IFIS. So if you think Iris Hooks was good, well, this is my presentation in ASCRS 2013, which was circulated worldwide. And it had a lot of other videos, but this is one where I'll show you where iris hooks were used. And this is what I am doing. I have 4 iris hooks in place, and my iris is coming out through all possible ports, and it looks more like a fishing net now, and it's coming into my phaco probe. So IFIS can be very, very bad irrespective of what device you're using. That's something we must understand about IFIS. So you see that was the main port, now it's on the side port. See that patulous iris like a sail? That is so typical of IFIS. Nevertheless, I got about this, and you need to make sure that the iris is out of the wound, and you can always use a side port instrument to draw it out from the incision. So that gives us around people at the end of surgery. Now this, if you think that I'm going to talk about the BX and say that's good, well, that's not good either. You look at the side port and you have iris prolapsing. It's not that the port is big, it's just that the iris is prolapsing and formed a knuckle over there. Now that's the main incision. So what does the device do? So we come back to this basic question is, how do devices help then? So IFIS, as we know, has got 3 components. We'll forget the floppy iris part. We are concerned about the meiosis and the iris prolapse. Whether using iris hooks or pupil expanders, what these do is provide a constant pupil size, which gives us good visibility, allows us safe phaco inspection. That is the take-home message you should be carrying. For iris prolapse, actually no device helps. Let's be very clear on that. Iris prolapse depends on the IFIS severity and pathological damage to the iris. So if you've got away one day with no iris prolapse in an IFIS case, it was just your good day and it was a low-grade IFIS. Do not give any credit to the device. So what you need to be aware of is use a device to provide you visibility so that you have a safe phacoemulsification. Now, there is another question which people ask and say there's a lot of bravado over here that I can do without a device. I can do in 4 millimeter people, I can do in 3 millimeter. There's only one question I want you to ask yourself. You are undergoing cataract surgery. You are the patient. You have a 4 millimeter pupil. What do you want me to do? Be a hero or use a device? If it doesn't cost much, it doesn't do anything. Even if it costs much, I would like you very much to use a device. So better be safe than sorry. We've all burnt our fingers. And if you look at the predisposing features over here, that's the whole list of medicines and the medical conditions. So practically every patient who walks into your theater is a potential IFIS candidate. So no amount of history taking or screening can prevent surprises. So brace yourself. Every case that comes into your theater is a potential IFIS case. If you think that pre-op pupil size, oh, you're a 7 millimeter pupil, 8 millimeter pupil in the OPD and you're damn happy, no, this is not a potential IFIS, well, this paper kind of contradicts that. Even for a pupil 7 millimeters or smaller, the risk of IFIS existed. And this paper was published in 2011. People say that, hey, we have a different color of iris, so we don't have IFIS. Not true. It's higher. The incidence of IFIS is higher in India. And in fact, hypertension is a very important risk factor. That's the alternate patient that walks into your theater. The good news is that now surgeons have lowered their threshold to use a device, and they are using devices easily because you know that IFIS is unpredictable. You've got premium IOLs being used, and of course, the society is going to drag you to the court, so you better save your back. So now we come to how do we achieve this mechanical pupil dilatation. We have 2 options. One is simple good old iris hooks, still holds good even in the present time, and you have pupil expansion rings, which could be the Mulligan ring, the BX, I ring. There are a number of rings. A basic thing is, where do you inject viscoelastic? Be very clear, do not inflate the anterior chamber. Your purpose is not to inflate the anterior chamber. Yes, by inflating you do get a little bit of extra pupil dilation, but you don't want, you're going to use a device over here. If you inflate the anterior chamber, the iris is going to get plastered to the lens capsule, and there's going to be no space over there. So you keep that AC slightly shallow, inject viscoelastic under that pupil margin, so lift off that iris so that you create space for your device. Small pupils are 2 types, very simple. Elastic or non-elastic. That's all is what you need to know. Once you differentiate that on the table, the rest of the job is easy, because that tells you how you're going to use your devices. With elastic pupil is like a rubber band. It's stretchable. Any pupil expander will work. A non-elastic or a rigid pupil may have a fibrous band. It's very much like a string. You can't stretch it. The circumference is going to be the same, so you got to tear it. How you choose to tear it is up to you. Whether you want to use the device to tear it, you want to use 2 Coughlin hooks, you want to use the iris hook itself, you want to use the Mulligan ring itself, or the BX. Now, BX doesn't have the strength, mechanical strength to tear the pupil, so we recommend a stretch always before using if it's a rigid pupil. How do you identify whether it's a rigid pupil or elastic? Simple test. Do your paracentesis, inject BSS through the side port. If that pupil expands momentarily, it is an elastic pupil. That's the surest test. If it doesn't budge, it expands very little, you know that you're dealing with a rigid pupil, so might as well stretch and use whatever. Even if you're using iris hooks, You stretch it to your comfort zone so that you have a nice round pupil at the end of surgery. You have a controlled stretch. Sorry. So what matters most is the elasticity of the pupil and not the size. It is not the size which is important. Let's do a little bit of basics of iris hooks. I mean, this is a very old video, but it still works. Side ports first, as far as I'm concerned, and like I said, keep it, and always make it clear corneal and slightly posterior dielectric. And I always like to put a conjunctival nick over there, because otherwise it's very embarrassing. You can't find your incision sometimes. So retract the stopper far enough, hold the hook sideways or posteriorly. Do not pull the hook all the way. You do not need a full dilatation, limbus to limbus actually. You need only about 5.5 millimeters. That's good enough. So I place my phaco incision generally after. When I do very little iris hooks now. I'm sorry, that's why the video quality is from VHS one. So while introducing any instrument, remember the pupil margin has been now elevated to the limbus margin. How much ever you try to angulate your iris hooks or whatever, it is going to be. And it is going to be a bit anti-flexed also over here. So your instruments, when you're going to put into the side port, it's going to hurt the iris. To remove, you just need to hold the stopper, advance that hook a little bit, turn it and just pull it, yank it out. You don't have to be too delicate, don't have to do heroics like turning it, twisting it, passing it across the AC. Nothing is required. This is nylon, it just stretches straight momentarily. No heroics required. Come to the BX pupil expander. Actually, this was my presentation in ACRS recently. And it is for 1.8 to 2.2 incision, it just walks in. A little bit of visco in the device over there, and hold it by the middle of the flange and just draw it inside. It just glides into the entry chamber. Tuck alternate flanges under the pupil margin, and you have a wonderful 5.5 millimeter hexagonal pupil. And it's so thin, the BX is so thin that it just doesn't come in the way of your phaco probe. I mean, you can move your phaco probe as if there is nothing in the anterior chamber, and there's nothing jutting out. So your phaco probe, IA probe can move freely in the anterior chamber. There's enough room for that. Any other device is pretty bulky actually, and it comes in your way. And if you look at it, you will see that IOL implantation also, it just doesn't come in the way. You just don't make sure that you just drag that posterior, the trailing loop goes in well into the bag. If you push on it, you tend to push the ring into the bag. And removal is so easy. Just hold a flange and disengage and draw it out. No device comes out so easily, and you have a wonderful round pupil. That's very important. It looks wonderful in the first post-op day. Now, this is what I presented at ASCRS. This is the smallest incision that you can take for any device that pupil expander that mankind has known. So this goes in through a 1.2 millimeter incision. So we are far ahead of the phaco and IOL technology that we have today. So even if you have to drop that coaxial incision to 1.2, you have a pupil expander which is ready. Only thing is you need to hold that pupil expander at the end of the flange, and it goes in through a 1.2 incision, and no better proof than a video. So we did in a series, we're actually dropping down the incision size. May not be very relevant now because most of us use either 2.2 or more. Some people use a 1.8. Now, removal, it can come out through a 0.9 millimeter side port incision, which again no device can achieve. So you need to disengage it and draw it out through a side port. It's so thin that it just comes easily, walks out of the incision, and you have no hassles. This could be very helpful in IFS when you have iris prolapsing through all your ports, or the AC is very shallow. Now, having used iris hooks for a very long time, I do have a lot of experience with iris hooks. I was instrumental in development of some of the iris hooks which is available in the market today. There are some issues. There is a lot of space in the corners which is wasted. We really don't need that. So we are stretching that place unnecessarily. The risk of infection, yes, at least theoretically it's there, and you do have sphincter tears. And like I said, the pupil plane is elevated to the limbus, so that is another issue. You need to be careful that your AC is effectively becoming shallow. And this was a study published in the JCRS where it showed that iris hooks definitely took more time than a pupil expander. Of course, it's a matter of experience, which one you're better at. There are many surgeons in India who are very fast with iris hooks, and they do a job very well. Full credit to them. We have all of us who've used rings over here, Deepak, Saurabh, myself, all of us have used iris hooks for donkey's years. So we know they still work. There is another problem. If you have a little bit of pressure issues in the AC, you might have marks on the iris. Now, how big do you want the pupil to be? We have a tendency to think bigger is better. Well, it isn't. It isn't. And especially for hard cataracts, you think, okay, we need big ones because we're not going to deliver the nucleus entirely into the antechamber in toto. You're going to chop it into small pieces. So why do you need such a big pupil? So a 5.5 pupil is actually more than enough. And as you'll see Deepak's video over here, Dr. Meghur, and you see just a little bit of stretch. This is a pseudo-exfoliation. Can get tougher than this. Pseudo-exfoliation, hard cataract, easy tucking of alternate flanges. Now you have a 5.5 pupil, and if you see, that is a pretty hard cataract. Yes, Dr. Deepak Megur is a very skilled surgeon, but if you follow the basic principles that you just chop the cataract into small fragments, the pupil size really does not matter. A 5.5 pupil is wonderful to do. So remember that even if you're using iris hooks, you really don't need to go beyond 5.5. So these are the features that you look for a device in IFIS. Should have require small incisions, should have a low vertical profile, can exit through the side port. So iris hooks or BX works fine. Now, intraoperative meiosis is another issue where devices like the Mulligan ring can have a problem because you cannot see that gap on the sides. In a top view, when you're using the microscope, you really can't see that gap. So you're not sure what you're engaging, whether you're engaging the capsular margin or the pupil margin. So capsular excess margin, so that can be disaster. Like here you see, when alternate flanges are tucked, you just draw it a little to the periphery and you have instant confirmation that you have cleared the capsular excess margin. You have not engaged the capsular. And if you by chance do engage, you are seeing it and you can always withdraw and go back again. Can I have the audio, please? Audio, sir? Sir, audio? So gaye aap.
In Asia, I believe, and in some European countries.
Just go back a little. So.
And welcome to the 20th annual AAO Spotlight on Cataract Complications. And this ring is very popular in Asia, I believe, and in some European countries. Again, it's FDA approved, and he calls it the B-Hex ring. And it's really, really thin. So this ring comes out really easy. It's flimsy, it's thin, and we pull it right out.
So no better person than David Chang himself, the god of ophthalmology, and showcasing it in AAO meeting is a real honor indeed. Of course, AAO has another video on its website, if you can look it up. It's a tube shunt, surgery in a tube shunt by Michael Henry and Deepak Edward. This is a wonderful surgery where you can see just one single port being used to tuck all the flanges, and there is a tube shunt over there, and this worked very well. So this has been watched many times in the American Academy. So there you see that flange negotiating the tube shunt, and that no device could do that. You won't have so much of control with any device. Rest of the phaco is pretty simple. So my choice of pupil expanders in intraoperative meiosis, something which can engage the pupil margin without catching the capsular excess margin. So my go-to devices will be either iris hooks or a BX pupil expander among pupil expanders. Choice of pupil expander in a subluxated cataract, well, without any doubt, it's iris hooks. Make no mistake, though, just because I'm the inventor of BX, I know I'll be partial to it, but I still will not use it in a subluxated cataract because it allows you asymmetric expansion. I can take as many iris hooks to as many hours that I need, and I can expand whatever side I require. So I'll strongly recommend you read this. It's available on social media and on our website. This is the BX Pupil Tips and Tricks. Most of our dignitaries over here who have used it, in fact, a lot more experience than me probably in the BX. So they can teach you a lot more than me. And this is something else that's available on eophta.com, 10 tips on phacoemulsification in small people. Thank you very much for your attention. If you're interested more in small people, be there in Ballroom 2 tomorrow, 9 a.m. We have a full course on small people where we'll talk of other aspects of small people. Thank you very much for your attention.
Thank you, Suvain, for an excellent talk. And the next speaker is Dr. Suvira Jain, a prolific surgeon from Mumbai. And she is going to talk on how to handle posterior polar cataracts. And thanks for telling that in subluxated lenses, iris hooks work well. Because in fact, I was going to ask you, tell me the one condition where you will not use BX. Yeah, correct. That's why. Thank you. So over to you, Dr. Suvira.
Irrespective of our level of experience and expertise as cataract surgeons, each and every one of us, when we take on a patient with a polar cataract, we are not sure whether or not we're going to end up with a PCR. I'd like to take this time now to explain to you and share with you what is my cumulative experience in over 2 decades of managing cataracts. So what are the real challenges that are seen with these patients? So what are we dealing with? We're dealing with a patient posterior pole, an abnormal adhesion between that and the posterior capsule, and an abnormal fragility of the posterior capsule. So therefore, we have to be very careful in our pre-op workup with the patients. They need to know what they are dealing with. What is the kind of cataract that they've come to us with? Tell them about the possibility of a guarded prognosis, suboptimal outcome, second surgery, make friends with your VR people, keep them standby, and have all your corrected IOLs of the correct power to be placed in different places should there be an opening in the PC. And remember, always what I have seen is that openings in the posterior capsule are almost always intraoperative. Having a preoperative PCR is extremely uncommon. This is one of my friend's case where in retroillumination, you could actually see an opening in the PC, which also matched what happened intraoperatively in this case. Now I'd like to take you through a normal case. Now this is a patient I operated last week. One eye operated for a trifocal IOL, polar cataract went well. So that's when the challenges are really so much more. So how would you manage the second eye of this patient? Obviously, you talk to the patient that there's the possibility that it won't go through. We may not be able to put in a trifocal lens. And I thought I should just start with showing you the tips and tricks that I use, or rather, what is the technique that I follow to try and achieve a better end result each and every time. When you're looking at making your incisions in a patient with a polar cataract, you should avoid any kind of struggle during instrumentation. So take care, meticulous care and attention to detail while creating the incisions. A gentle wash, a gentle injection of blue dye. You don't want to inject too much. You don't want the pupil going down. With viscoelastic in the eye, then you plan a capsulotomy. We all know that we plan a rhexis, which should be about 5 millimeters, not more, for the possibility of a sulcus placement. Having completed your rhexis, very little depression. I try and maintain my anterior chamber always at the correct optimal depth. And we never do a hydrodissection. You do a hydrodelineation, where you inject at a particular depth to create a particular size of an endonucleus. Minimum manipulations during phacoemulsification. I like, if the cataract is soft, to impale into it, bring it up so that all the manipulations thereafter are above the area of the rhexis. In that manner, I'm able to facilitate minimum exertion of forces within the capsular bag that could compromise my posterior capsule. The most important step is this, that at any point before bringing the source of irrigation out of the eye, always perform a viscofluid exchange. Now you've got an empty bag. So through the empty bag, it's quite a good idea to do a viscoprolapse of the endonucleus, bring it into the center, and then in the epinucleus mode, it can be very easily aspirated. You hardly need any energy here. Once more, before getting the probe out of the eye, perform a viscofluid exchange. I like to make sure that before I do a bimanual eye, I have a perfect focus on the entire capsular bag, so I don't need to struggle to see. Again, I like bimanual eye because that allows for a circumferential removal of the cortex. And even when you're changing hands for the bimanual eye, always do a viscofluid exchange, because you want not for the anterior chamber, for the posterior capsule to come anteriorly at any point. At the end of the cortex wash, once more, take your time, do a viscofluid exchange. Even if you see a few cells on the PC, refrain from doing a PC polish, because these capsules are fragile and you could always yag it later if required. Care and caution here with counter pressure with the Sinskey hook. Take your time injecting a lens into the eye and then carefully into the capsular bag. Once more, when you want to do your visco wash, take time to do it carefully. This is one of my slowest steps in the surgery. Avoid excessive rocking movements on the PC. In these cases, even avoid tipping up the lens and going behind it, because I want to take care that I don't end up damaging the posterior capsule at any point. And right at the end, with the irrigation still in the eye, I do a stromal hydration of the incisions, and that gets me to the end of the case. And this is what I follow again and again, and almost always I manage well. I'd like to now share with you a few cases where there was an opening in the posterior capsule, the strategies used, and how I managed these cases. Let's start with case 1. The first and most important thing to know is, when is it not a rent? Typically in polar cataracts, you see this condensation of the posterior cortex. It's a fixed condensation. It is not a PCR. Unlike that, if you look at this, when there is a PCR, there's a flaying open of the PC because of the force of the irrigation. This is what a PCR looks like in a polar cataract. This is quite an old video. I managed with a play between, there was no vitreous disturbance. I managed with a play between IA and also dry aspiration of the last part of the cortex under viscoelastic, which gives you a certain extra element of safety. This is a patient wherein the nucleus management was uneventful, and when I got on to removing the cortex, I could see before my eyes the typical elliptical, equator to equator opening in the PC. However, even at the end, you can see that there's no splaying open. When I did a viscofluid exchange, my PC is not damaged, the vitreous is not disturbed. So I actually managed, with care and caution, to place a single piece monofocal plate haptic IOL with care in the manner described here in the capsular bag. For that, of course, as Saurabh also discussed, it's very important to make sure that the vitreous is not disturbed. You don't want to put a lens in the bag and then be dealing with vitreous. We now move to the next case. This is a patient with a NS2 to 3. This again is a very old video. It's a controversial thing, but in harder cataracts, hydrodelineation is slightly more challenging. There's always a tendency of the fluid to go subcapsular. Now, the first chop seems to be going well, but there was a significant lateral separation, and you can see how the nucleus is starting to sink. About a decade ago, this is what I did, and the way I'm showing it to you now is I'm not certain it's the best of ideas. I put in a 26 number needle through the pars plana, prevented the fragments from falling, got them up, and it's always difficult to bring out of the eye smaller fragments as opposed to an entire nucleus. And then the fragments are brought out of the eye, followed by an anterior vitrectomy. Today, if I had fragments falling, I would just let them drop, which I will show you in one of the coming cases. At the end of the limited anterior vitrectomy, the cortex is removed using the aspiration mode alone of the vitrectomy, a little bit of this, and finally a lens is placed in the sulcus. This, we had a big incision anyway, so I put in a rigid 5 mm lens with care and caution in the ciliary sulcus. The patient had a good end result. Here's another case. This is a patient with a very soft polar cataract. And even despite doing everything by the book, a good, careful hydrodissection delineation is done here. And at the end of hydrodelineation and under viscoelastic, as soon as I put my probe in the eye, see what happens. I'm going towards the nucleus, and the entire PC opens up. Because it's so soft, I can see it flaying behind. And clearly it's a very soft cataract. This is the kind of opening. I've got my probe in and nothing has come out at all. I haven't aspirated anything. So without bringing the probe out of the eye, I do a viscofluid exchange. And I just try to remove a bit of the cortex with IA because there's no vitreous disturbance according to me. But that didn't seem to work. I got very little bit of it out. And then, of course, there was some vitreous disturbance. So I then proceed to inject a little bit of 4 milligram and 0.1% of triamcinolone. I do a limited anterior vitrectomy with a cut eye, but most of the cataract is just a very, very soft cataract. And watch how only in the IA cut mode, that is only in the aspiration mode, I remove the right half of the cortex, and then once more here, to prevent any further vitreous disturbance, I put in some more. I do more of a viscofluid exchange, and then I remove the rest of the cortex. This is just the nuclear epinuclear sheet, actually, all of that. And finally, the last bit of the cortex is also removed. Viscofluid exchange at all steps, and then you can see at the end of the surgery, after this, I go in and place a 3-piece lens in the sulcus, but there was an extension of the tear, which I then converted to make it into a stable opening. And I actually managed to put in a single-piece monofocal IOL in the capsular bag with care and caution. And then I rotate it. You always rotate these lenses to come to lie at right angles to the tear. Center it well, remove the viscoelastic, and then you can be quite happy with the end result that you have achieved here. This is a case with a little harder cataract. So what do you do when you're performing a polar cataract surgery? Again, as you can see, these hard cataracts, it's slightly difficult to perform a hydrodelineation. First chop, again, try and do a limited lateral separation. This is a little more than I needed to. Remove a bit of the nucleus. Now watch what happens when I'm trying to get some part of the nucleus out. I actually notice suddenly in front of my eyes, as I'm trying to downsize and emulsify, one big fragment starts to drop. Now, if you have a fragment that's dropping, what you do is you just don't do anything. You let the fragment drop. Now, there's just a little bit of a fragment there. I reduce my settings and I try and emulsify this tiny bit of nucleus that's there. I perform a viscofluid exchange and I come out of the eye. Then, because there is a vitreous disturbance, I perform a limited anterior vitrectomy, call on my VR colleagues. They're still very grateful if you do a good limited anterior vitrectomy, if you remove the cortex, and even more so if you place a three-piece IOL in. Here, I placed a rigid lens in the ciliary sulcus and suture the wounds before handing it over to them, so that then they can come in with their instruments, go in with pars plana, and remove the rest of the sittings. I would always advocate doing this second surgery at the same sitting itself. This is just a case I found, I thought I'll show it to you. It's actually a post-vitrectomized eye which ended up with this polar opening in the posterior capsule. So with care and caution, I've actually thinking that the patient would have limited visual issues because of it. I've actually managed to do like a posterior excess, which today perhaps I would also use a forceps to complete. I've removed this opening, at the end of which I find that there actually is still no disturbance in the vitreous, and I manage once more to place a single piece monofocal IOL. You got to do this under visco with very good visualization to make sure that it actually goes under the anterior capsule and above the posterior capsule. And at the end, we had a good end result. In the next case, this is a case that belongs to a colleague of mine, Dr. Matthew, and he's done what you shouldn't do in a polar cataract, that is a PC polish. He's ended up with an opening in the PC. Now, even if you do end up with a limited opening, though it was a polar, he's just had a limited opening here, not a typical elliptical opening. Convert that little opening into a stable circular, or even if not circular, it should be converted with care and caution into a stable opening. Once you get a stable opening in the posterior capsule, you're then safe to put in a single piece or a three-piece lens in the bag. And that's what's happened here. He then chooses to put in a three-piece lens in the capsular bag because obviously that gives you a lot more stability. In putting in a three-piece lens, I would just advocate making a big incision, getting the nozzle right up to where you want to inject, and then inject to make sure and to ascertain that the haptic goes where you want it to. And it's not over till it's over. Even stromal hydration itself can sometimes end up with an overpressurized eye, which can result in an opening in the posterior capsule, which happened in this case, which was actually missed and seen the next day. I'll end with my last case. This was a live surgery done about 3 years ago in Bhopal, wherein I said, all right, I'll operate on a polar cataract. And there is a very dry cornea, so you could see an epithelial irregularity. A well-done hydrodissection, hydrodelineation after a carefully performed rhexis. Hydrodelineation is good. It's just an NS2 cataract, and I thought, what the hell, it's going to go really well. A limited lateral separation, and I proceed with creating a small little wedge of nucleus and bringing it up. Low flow settings with power only adequate to aspirate, to emulsify the nucleus. Limited vacuum just to bring the fragments up after impaling and burying into it. And the nucleus management seems to be going on rather well. So I'm happy. I'm saying, okay, case to ho gaya, world watching. I correctly perform a viscofluid exchange, and I start to do a viscodissection and then aspiration of the epinucleus, as you can see here. At all steps, I'm mindful and I'm careful to perform a viscofluid exchange. And now I think most of it is over. So this is live, yeah? And I start to aspirate the cortex. And in front of my eyes, I find that now you will see that when the right half of the cortex is almost coming out, you can see the typical elliptical opening of the PC there. Everything is done by the book, according to me, and according to most of my friends who are watching as well. Then I decide, now what do? I said, okay, we've got to manage this. So with a viscofluid exchange at every step, the last part of the cortex is then removed. Because there was no vitreous disturbance, I actually was brave enough to go in with a bimanual eye and remove the cortex. Now, even at the end of cortex wash, my posterior capsule had not, the opening in it had not opened any further. I do a viscofluid exchange. Oh, and the plan was for an EDOF lens in the back. And typically in a life surgery, there was no standby 3-piece IOL. So I managed, and then you need them to center well because you can't have a decentered multifocal lens. But to my good fortune, I was able to put the lens and put it in the capsular bag. Thank you very much. This is my experience that I wanted to humbly share with you.
Yeah, thank you, Dr. Suvira, for showcasing many cases of posterior polar cataract. And now we have another stalwart in phacosurgery, Dr. Deepak Megur, and he's going to talk on subluxated lenses, how to handle subluxated lenses. Over to you, Dr. Deepak.
कनेक्ट है चेक करो आ रहा है कि नहीं Dr. Bide, thank you for the opportunity. Dear friends, I'll be speaking on management of subluxate cataracts, and the theme of the session is what will you do for this case. Now, he is a 65-year-old gentleman who presented with this intermittent cataract, but also has this 4 o'clock hour zonal dehiscence in this. So we have got multiple challenges to deal with. The first would be obviously, deal with the zonular loss part, and second, the rexis issue as well. The first thing always is before you even do or touch the anterior capsule is always try to rule out the presence of vitreous in such eyes. And diluted triamcinostate staining confirms that there is a transzonular migration of the vitreous which needs to be dealt with first before even touching the anterior capsule. So with the irrigation bimanual anterior vitrectomy, you take care of the prolapsed vitreous. I'm using cohesive OVD to ensure that the chamber is maintained and I can get my rexis right. The most important step in all subluxated cataracts is to get the rexis right. Because if you get the rexis right, then you can use all the capsular bag stabilizing devices. So because I could get the rexis right, I am placing my capsule hook in that segment. And I'm going to support the bag by using CTR now itself. The idea is when you stretch the bag, the CTR is placed in such a way that the zonular weakness is supported first so that there is no worsening of the zonular tear which is already existing. Another reason why I'm placing the CTR early is it also provides an equatorial expansion which minimizes the migration of the fluid across the zonules into the vitreous, which can cause fluid misdirection. So you're always going to replenish with OVD and try to ensure that the vitreous is not prolapsed yet. And if it is prolapsed, again go back and remove the vitreous before going into managing the nucleus part. So only greatest virtue one has to have is patience in such cases. You have to be very patient. And the white plaque what you're seeing is actually the triamcinolone which is migrated behind the posterior capsular bag. So we need to remove that, and in this situation I am going to do a pars plana anterior vitrectomy. The irrigation is going to be through the anterior root itself, but I am going to manage the prolapse, transzonular prolapse of the vitreous. I want to deal with it by using the pars plana approach. Care is to be taken that we don't perforate the posterior capsule in this situation. So we have a CTR in the bag, and in this case, of course, you could have always gone ahead and put it in the bag itself, but here I'm trying to achieve the optic capture and try to have an IOL trap technique. The patient is old and maybe having a little bit of a pseudo exfoliation. That's the reason I put, but you can always go ahead and put it in the bag itself. Always ensure that before closing, the eye is totally free of vitreous. And whenever you do vitrectomy, try to ensure that all the wounds are watertight and close sealed. So these are the post-operative outcomes of this patient, and they usually are they do very well. Now moving on to the next scenario, which is very commonly which we see, that is pseudo exfoliation and generalized zonular weakness. This is probably every fourth or fifth case in the list will be like this. You have the extra space between the iris and the lens, suggestive of a generalized zonular weakness. When we touch the capsule, the wrinkling of the anterior capsule again indicates there's a generalized zonular weakness. And these are the situations where either you have to fix the bag using two segments if it is very significant, or you have to compromise the bag. So got multiple options available here. Either you have to save the bag or sacrifice the bag and put a scleral fixated lens or an iris claw lens. But in situations where it is not so dramatic, so not so worse, maybe a moderate density, which I shown here, you can still salvage the bag and maybe fix the lens in a slightly different way. The traditional way has always been put the CTR and the IOL both in the bag. But the one issue is, there's always a tendency for late dislocation and decentration, apart from the massive pseudophacodenesis which we see. So I've been using this IOL trap technique for some time now, maybe for the last 6-7 years, where the CTR is placed in the bag and we place a multi-piece hydrophobic lens in the sulcus with an optic capture. So let us try to understand the principles. The first thing when we manage a pseudo exfoliation case is to ensure that we are seeing well. And you can use an iris hook or a BX device. My go-to device has been the BX device in these situations. It does a pretty well job in most of the situations for pseudo exfoliation. The most important thing is to get the rhexis right and its sizing right, because if you're aiming for an optic capture, you cannot have a rhexis which is more than 5 millimeter. It has to be at least 5 millimeter or 4.5 to 5 millimeter. Hydrodissection is probably the very important step here, because before we venture into nucleus management, we want to ensure that the cortex and the nucleus are truly away from the capsular bag. And early insertion of CTR is a very critical thing in my practice. I always prefer to use this. Well, there is always an option of using 4 capsule hooks as well. But once if you're able to put in a CTR early enough, I can avoid making those extra 4 incisions. That is a reason why I prefer to use the CTR. And then obviously the phacoemulsification, usually these patients are elderly, the nucleus will be dense. You will have to be having a very controlled way of managing this nucleus. The nucleus division technique of your choice will do the job, but only thing is you need to ensure that you're in good control. Cortex aspiration with the presence of a CTR can be challenging, but if you use the tangential method of stripping, it is not going to be a major issue at all. Again, you can use the bimanual to retract the iris along with the BX hook, and then see that you're under direct visualization. You can actually strip the cortex around the CTR itself. This is the step where most commonly people get scared and are of losing the bag, but if you're careful, it can be done. The final step would be to put the multi-piece hydrophobic lens into the sulcus here. So we are removing the ovary behind the lens and in front of the lens, and then with the irrigation cannula in my non-dominant hand, I'm pressing the IOL back into the capsular opening so that I get the ovalization of the rhexis. This indicates that we have an adequate optic capture. So this is the way we stabilize the lens. Now, this is another case where patient has very complex pathology, like non-dilating pupil, compromised zonules, and the zonular health can be assessed only once you touch the capsule. So I'm trying to mobilize the nucleus after doing hydrodissection. You can see that the entire bag is moving. So you may not have sort of phacodonosis at the slit lamp, but actually you start handling the lens, you really know how bad is the situation is. So you have a generalized zonular laxity here. So one trick here to put the ring early when you have such a swollen lens is that you need to create some space. I aspirated a little bit of cortex and I'm using cohesive OVD under the anterior capsule. That creates a little bit of a space for us to easily negotiate the CTR into the bag here. So here you have a 360-degree zonular laxity here. So once we put in the ring, we are provided with that support. And of course, the nucleus management is going to be standard technique. And once you're done with it, you are going to achieve this optic capture. So this is how the eye is going to look in this. So this is, in my opinion, the best way to deal with the eyes with pseudo exfoliation with long term. We're expecting it's a progressive phenomenon. So basically, what we're thinking that the lens itself is supporting the bag rather than the other way around. So the lens is supporting. I have a reasonable experience of most 6 to 7 years now, and this is been the thing. Primary benefit, obviously, the centration stability is better, but one secondary benefit which I have noticed is the reduced incidence of pseudophacodonosis in these eyes. So the principle here is, you are getting an equatorial expansion, 360 degrees expansion by the CTR, which is in the bag, and the hydrophobic lens in the sulcus. Basically the haptic in the sulcus and the optic is pushed back in the rexus. This sort of redistributes the weight around the capsular bag complex, and this ensures that actually the lens is somewhat holding the bag. So of course the time is going to tell us how long it's going to stay there, but this is one way of trying to deal with these eyes, with a very common scenario of eyes with pseudo exfoliation and generalized zonal weakness. So two things are very critical. One thing is we have to get the rexus right, which is well centered, and hydrophobic lens is important because we can see this fibronectin secretion on the capsule, which actually ensures that the lens is sticking onto the capsular bag. So this is what is important. This we can't achieve with an hydrophobic lens. So a multi-piece hydrophobic lens is important rather than hydrophilic, and this is what ensures probably that the lens will be holding the bag for some time to come now. So moving on to the next case scenario, the next case scenario would be like where we are going to not able to save the bag in extreme cases of zonal adhesions. Like this case, this is microspirophakia in a very young patient, and obviously it is too compromised to attempt any sort of a bag salvaging procedure. We have an option of doing a scleral fixated lens, or the other easier option of putting an iris claw lens. So of late, maybe 3 years, we have shifted more to the iris fixation, the lens, and this I'm going to demonstrate one such case of an iris claw lens in this patient. So here the aim is to deliver the nucleus in a very traumatic way. We obviously know that there is a subluxation, and there is also the vitreous is already probably disturbed, so as was evident in the slit lamp picture. So once we create we are creating the scleral tunnel of adequate size. Is about 6.5 millimeter. Now for iris clip lens, as we all know, that comes only in PMMA rigid lens. So when making the side port incisions for fixation, this is extremely important that we just mark it and then use a very short tunnel. So it has to be very short. We don't want to have any tunnel here. So direct stab entries would be much more easier for us to do the enclavation part. Now in this case, I'm just going to do an visco expression of this case rather than using any instrumentation. So you don't want to drag the vitreous in these eyes. So what we are doing is just going to use, there is no vectis or anything. Just we are going to use viscoelastic under the lens, and it's just going to express it out. So this is probably a very traumatic way of dealing with the nucleus here. And this patient is relatively young. The nucleus will not be very high. Of course, this is a case of a spirophakia. And once it is done, you need to ensure that before putting the intraocular lens implant, take care of all the prolapsed vitreous. So the common question which is always asked to me is that on the outset, the iris claw lens appears to be very easy. Can we do it without a vitrectomy? I think the most reason why most of the lenses get a bad name because we don't do a proper vitrectomy. The most important step is to do the anti-vitrectomy in such cases. So diluted pilocarpine is important once you're ensuring that the vitreous is taken care of. We don't want the pupil to be too small. We don't want the pupil to be too big as well. So dilute it with pilocarpine and then do this thing. Iridectomy is done with the cutter itself using the IA cut mode with the lowest cutting which is possible in the machine. Just push, aspirate the small vitreous, small iris, and then make a small nick. And in some situations where the tunnel area is not so clear, I did use an inferior quadrant here to do an iridectomy because the visibility was not great here. So we're going to place the lens in the horizontal 3 to 6 meridian in this plane where you want to actually locate. And I'm using this Clayman forceps. The one trick I would like to share here is that the notch which is there on the haptic, I usually position my flanges of the forceps exactly at that area so that I can localize the position of the notch when it is under the iris. So the lens is pushed against the iris. I'm going to use a blunt cannula. This is a 26G cannula rather than an Sinskyuk so that we don't create a hole in the iris. It is the lens is pushed up, and just beside the where potential claw is, I'm going to tap the iris once, and you can see a small puckering which is happening there. I can do it one more time, and just to confirm that the iris is totally engaged, you just move the lens so that the iris also is seen the movement. This ensures that the enclavation is perfect, and now you can go ahead and enclave the other end, because most of the times people are worried that you are going to drop down the lens. But once you're sure that your enclavation is perfect, and that is the way to test whether your enclavation is perfect, then you can always go ahead and do this. So the same thing, you hold the lens in that particular position so that you know where to tap on the iris. So again, the lens is pushed forward, and the blunt cannula ensures that you just tap it down, and you can see this pucker which is happening. And ideally, the enclavation has to be done in the mid periphery or the as much periphery as possible. This ensures or prevents the ovalization of the pupil, which can happen. So this was one case, and so that was it. I think that was the case. I'd like to. I think the time is up. I'd like to stop here, and thank you so much for attention.
So we are at the end of the session, and we have one more challenging situation in the form of hypermature cataract or intumescent cataract. So let's start. We all face similar situation in our day-to-day surgical practice, and we have now eminent surgeons here. Here again, I'm trying to do capsular access with 26 gauge cystitome. I'm unable to rotate the flap. There is a lot of intralenticular pressure. I'm trying to aspirate through the same 26 gauge cystitome, and there is already a centrifugal pull by the zonules on the tense anterior capsule. So I want to reduce the intralenticular pressure, and I'm trying to aspirate the intralenticular fluid. So here I have aspirated intralenticular fluid, and now I feel that I will be able to complete the capsular access in this case. And here it is, the extension to the periphery. Second situation is similar. I think since we are short of time, I'll skip with the second case. The third case is same. It's a hypermature cataract intumescent lens. A proper staining is must in such cases for visualization. Here, once I have taken the nick, I have realized that there is a lot of intralenticular pressure and it's going to rupture. So immediately I came out of the anterior chamber, and now my aim is to reduce the intralenticular pressure by aspirating the intralenticular fluid. The nick is very small, so I have gone inside. I'm trying to tap the nucleus and trying to aspirate, but already the tear is extending, and the tear has already extended. So now what to do in similar situations? Now here is a case. Again, I have almost finished the capsular access. It's going to the periphery. So in such case, if you want to avoid the capsular access from going to periphery, you just have to give a pull towards the center. This is case scenario number 2. Again, the intumescent cataract. Our aim is to perform a small capsular access. Anterior chamber has to be maintained deep throughout the surgery. But we all know that there are 4 types of forces which are acting while doing capsular access. The extrinsic force, which is of the surgeon. The second is the centrifugal force. Now here I could manage the case easily. So doing phacoemulsification in such situation was not that difficult. It's always better to do stop and chop in such cases because you have a full control on the machine and on the fluidics, intraocular fluidics during surgery. You can also use a coaxial eye. In fact, I prefer to use coaxial irrigation and aspiration system over bimanual because it is quite fast and we are used to doing with coaxial. Now this is a case scenario number 4. There is a lot of milky fluid. Once you puncture, now here, oh sorry, I'm sorry. So I have question for the esteemed faculty that how will you handle such cases? What will be your preferred viscoelastic devices? I think will yeah.
All the problems with that in the last 2 months, you will be surprised to know there is no small people, there is no DCR people. If you see very clearly, if you see in 3D, if you see a posterior capsule lying here and the capsule lying here, and if you see the vitreous, and you can change the colors of the vitreous. I'm talking of 3D digitally assisted phacoemulsification. I have more than 35 years of experience with 2D phacoemulsification, but only a few months. I've done about 300 cases, and it is not only the cataract, and it is not the machine came for the vitreoretinal. People started with cataract, but I have done from cornea to macula, all surgery under 3D. I have a team also. So you see so clearly, you have such a depth without losing, without distortion. You any amount of magnification you can have without losing a depth.
So are you talking about the Ingenuity which is there?
Yeah, I'm doing anything.
Yeah, but sir, how many of us have access to Ingenuity?
That's a different thing.
Yeah, out of 21,000 ophthalmologists in India,
You will see,
I think less than 1% have access. So
we used to talk like this.
I accept what you're saying, but
I only think we cannot show it here because you don't have 3D glasses. You don't have 3D skins. I'm sure the next conference there will be many people. There will be some.
Yes, sir. Thank you.
Some sort of new things coming up because the things become so easy, so clearly that you are able to do so many things. It is so easy. Very hardest category is too big. You take a hard caster with a high vacuum and you go behind, you engage the corner of the, and you will break it.
Yeah, thank you, sir. So,
Without damaging the endothelium
Yeah.
and the prostate
yeah,
capsule.
thank you. I would like to have opinion from the senior surgeon, Dr. Yogesha, Dr. Suven, Dr. Deepak, Dr. Madhav Ambekar, about all these challenging cases. Because what you said is correct, but we don't have access to such hi-fi systems. So let's talk about practical things.
Yeah, thank you, Santosh. Sorry, I have not seen all of your cases. But
Yeah.
the case 3rd and 4th which you were showing,
Yes.
I think one thing which I would certainly like to emphasize is the use of heavy viscoelastic material. Ultimately, what you need to have is higher intraocular pressure than the higher intralenticular pressure.
But sometimes if you use high molecular weight visco, it can run to the periphery. Like, Suven, you want to say something? Yeah.
Uh,
Yeah, you finish with it.
Basically, if you start injecting the heavy viscoelastic material away from the area where you have punctured,
Yes.
and gradually as it goes over there, it will pressurize the whole thing before you proceed. I'm not sure actually whether it was done or not,
Yeah.
but that is one thing. Whether you can aspirate one place where you showed that there was a small tear
Yes.
when you went intralenticular
Yes.
to aspirate the cortex out.
Yes.
That itself also, even the introduction of your cannula itself can
Loose paper, loose rough
extend the
paper.
tear and make it
Yeah.
move to periphery.
Okay.
I would have preferred rather not to go even. You don't need to go inside the capsular bag.
Back. Okay.
Right over that point, if you have injected a very heavy viscoelastic material and suck it out, then I think it's fine.
Yeah.
These are the two videos I just showed.
Yeah. Okay. Dr. Maybe Suven and
Yeah.
Dr. Deepak.
So
quick.
there are two aspects. One is the OVD that you're injecting, and second is how you're going to tear the capsule. So OVD injection at different stages in different places. So if you're injecting a high molecular viscoelastic in the center, when we start the capsular access, you want a deeper anterior chamber. And if you look at Deepak Megur's videos, there are situations where you don't want a very deep anterior chamber. So there are when we are starting the capsular access, we want to inject viscoelastic so that we flatten the anterior capsule and they don't have a dome because the capsular access tends to run downhill. Now, when you have a tear which is running to the periphery, you want to inject viscoelastic at the tear and beyond the tear, not in the center. Because when you inject in the center, what you're doing is the liquefied cortex is being pushed to the sides as a donut. And when it becomes a donut, your tear is going to extend further. So you inject your injection of, because as a reflex, we tend to put in viscoelastic into the center of the antechamber, and that is doing more harm than good. So that is one aspect. Now, once you have formed the antechamber, you got a little bit of stability, we look at how we handle the capsular access. There is nothing like Little's capsular access. So anyone who's not read it should go back and read Brian Little's article. There are various interpretations of it. It is very simple. Put the flap back.
Sometimes it is difficult to put the flap back because of the bulge.
Agreed.
Most of the times. And then it goes to the periphery.
Then we would have become infallible. So that doesn't happen. We still have best of best surgeons have the Argentinian flag. So, but ideally, if you can do it, you put the flap back, hold the flap close to the apex of the tear, and draw it back to where you came from. Your capsular access is going this way, you drag it back this way, and your tear extends centrally. The forces you use are very different. Where was the rough paper you were giving me? This is the rough paper? Yeah.
Dr.
This is
Deepak,
cardboard.
you want to say something?
This is cardboard. Okay. Yes. So there are two forces that we're using. So let me just, so that's, when you're usually doing your capsular access, you're using what is called a rip. What you want to do is actually do this. You want to pull it tangentially. You don't want to pull it in different planes. You want to pull it in the same plane. That's when it turns back towards the center. That's something you must read up, and every surgeon, I think, must read up. These are the two pearls that I would like to offer.
Anybody has any input towards doing a little bit of a vitrectomy at this particular point of time? Anyone having any input?
That's a little bit too dramatic step, I should say, for dealing with intermittent cataract. But the point which I'm trying to get to you is you want to have a soft eye. That's the basic principle.
Correct.
I think the first three basic principles you need to understand. We need to have a softer eye. So for softer eye, you can use any message, because when you're doing on a topical anesthesia, patient will be moving eyes here and there. That itself can raise the pressure inside. That can contribute for the rexus running away. So you can have a soft eye by maybe giving an IV mannitol or pressing giving a block or pressing the eye. In the last case scenario, you can do that.
You must resort to the-
Correct.
We used to do a lot of it when we were training.
Yeah. So no, that really works actually.
Yes.
And the one thing which I would like to do, sir, decompression has to be done only when you have a small rexus. So when you all of us are doing two-stage rexus, the incidence of the rexus running away has reduced dramatically. You don't have enough time to puncture and come out and go for a forceps. You don't have that much time. By the time you do that, it goes on.
Yeah.
So you first have to puncture and finish the rexus. So my go-to instrument is, have a viscoelastic which stays there for long, never allow the chamber to shallow. Puncture the capsule, finish the small rexus 3 millimeter. Then you have all the time to do. Once you have a small rexus, you can decompress. Decompressing with a capsular edge which is irregular, as sir was telling, the moment you introduce something, it's going to go away. So you cannot introduce into the bag anything if the capsular flap is ragged.
Okay. Do you use micro scissors anytime?
Yeah,
If it is going to the periphery?
No, even in this aspect also.
Fibrotic, yes. And in fibrotic, some people have even used vitrectomy cutter
Yes.
just to cut it off.
Dr. Saurabh, you want to say?
Fibrotic capsules are safe.
That was actually, I think, your presentation. I was there during that presentation.
I think one thing what I felt last 2 years, we are using the wrong OVD for these cases. I think the best OVD for this is the AIOC. So I don't have any financial interest. It is 5 times heavier and viscous than Viscoat. Viscosity is not good enough for this. You either use 2.3% Hernate or use AIOC, which has similar combination of Viscoat but 5 times heavier. And you will find is that when you use that OVD, even when you are doing anything from the side port, nothing comes up. If you use Viscoat, you will find whenever you go in a little bit of Viscoat leaks, that little bit of leak is enough for adaptation flag. So I think if you shift to a better, we need better OVDs to deal with these.
Precisely.
Don't don't try to do maneuvers with lesser OVDs. That's not going to.
Okay. Dr. Suvira,
I
you
think
want to say?
Suvira
I would agree with Dr. Meghur. This is what I do, that none of us can control whether or not you're going to get an Argentinian flag sign. But till now, the only safe technique that I have found is I use Halocoat as well, a heavy-duty viscoelastic, a controlled incisions. Make sure your cystome is not damaged. And with your initial puncture, I don't make it in the mid-periphery like you, because that to me is dangerous. I make it in the center, hold on, and I make a tiny small rexus. Sometimes I to make that small 2 millimeter rexus, need to bring the cystome out, because the cystome doesn't always fashion the entire rexus because you don't have a lens under it. Once the small rexus is there, it's safe. You wash it out, put in some more, and you can make any
Any
size
different type of cystitome you prefer? A circular one like Dr. Rajinder? Sewing machine?
I like the ones that I
capsular
make.
rexus?
I don't let the nurses make them.
Suvira, I don't
Okay.
remember. I
Ji, sir.
just saw in the last AIOS, someone
Yes, sir.
presented.
Sewing
he
machine
uses
technique.
the FECO 0-degree tip.
Puncture axis.
These
It
are
doesn't work.
dangerous. I think
Puncture axis doesn't work. Puncture axis.
He demonstrated in some of the cases. I have
Dr.
no
Mohan
personal-
Rajan has
I
demonstrated
think
it.
eventually you want a technique that is repeatable, reproducible, and safe.
Safe, yeah, okay.
Saurabh, in your presentation, one of the things which I was just wondering, how would you, in how many percentage of your cases, when there is a PCR, there is intact anterior vitreous phase?
Yeah, so this commonly happens when the PC rent happens either at the end of it by touch or during IA, when you are doing IA, when it happens, or I have seen it happening in posterior polar cataract when you remove
That-
everything and just it over.
Because usually most of the time, and I don't know, I mean, I thought possibly there was no demonstration of vitrectomy through the pars plana, which I think every anterior surgeon should learn, and Suvira has been possibly teaching that kind of a thing.
Anybody from next session is there, or we will go with audience queries? Yeah.
On that
Sure.
Yeah.
No. Okay, so one thing about puncturexis, I was a judge when this was being presented for the Kannada Rangachari. So I asked Dr. Mohan Rajan only one question. 0-degree tip. How do you position it to become 0 on the capsule? In fact, you'd rather use a 45-degree tip, then you get all of it on the capsule if you really want to use it. You cannot position a 0-degree tip at any angle entering. You cannot go
Yeah.
vertical unless you have L-shaped.
45-degree upside down.
Upside down, it's a
Yes,
big ask. It's a big ask, and you're playing with chances. So, and you really don't want to do. I think we tried time-tested methods. Absolutely.
I was not successful.
And I didn't even attempt it.
So I think take-home message is use good viscoelastic devices while doing hypermeasure. Any queries from the audience?
One like the thought process what we have during capsulation in the intubation cataract, there should be no fluid movement anywhere. I think when you achieve that 100%, there will not be any action.
No, but once you puncture the anterior capsule, the fluid will definitely egress out of the
Across the incision.
across the incision. Yes, there should not be egress of fluid.
So there's one simple thing in science.
Yeah,
If you have too many hypotheses, we still don't know about it.
yeah.
Correct?
So still it is
We're
evolving.
still there.
So,
We're still struggling.
yeah,
If
yeah.
we knew a one shear shot method, because the intumescent cataracts present in very many ways. There are the other theories of pre-nucleus, post-nucleus compartmentalization.
Yes.
There are innumerable theories. So we are not there. We don't have an understanding. Yes, we have high molecular. We have better tools.
Yeah.
But probably
In fact, there is a OCT study also of intumescent cataracts.
Understand whether we have understood it completely is try it with the beginners. Give them different techniques and try to find out which works best.
Better. Yeah.
Let's see how the process.
No, I believe we will achieve.
Yeah.
We will, sure.
Okay. Yeah. He has one query.
Concepts use is one thing that I have.
Yes. Another thing
The
is
problem with microforceps, you should be used to using it,
yes.
not in a crisis. When you get into a crisis
Yeah.
and start using it, then it becomes.
Saurabh, tham ek minute.
Using it in all the cases.
Yes.
And I think through side port, if you do, there will be less egress rather than doing through main port. Yeah. Okay. I would like to thank all the audience for being here, and special thanks to Dr. Yogesh Shah, Yogesh Bhai, and Madhav also. We'll have one photo of faculty. Yeah.
Put up the light. ये इसके लिए background में मत
अभी नहीं, लाइट नहीं आएगा और फिर से निकाल के बल्ब निकालेंगे अभी लाइट परमानेंट क्या है
watch. That is projector go off.
It was a great idea.
कुछ नहीं दिखता है
Yeah.
परमानेंट क्या है बल्ब अभी सुबह से झगड़ा हुआ है पे मतलब ऑडियंस कुछ नहीं दिखता है प्रोजेक्टर का लाइट
Against light. नहीं उसमें background नहीं आएगा.
We can stand there. Would you like to stand there?
Yeah, I think that's better. That's better. It's on. Light नहीं है. आप प्रोजेक्टर को बंद कर दो ना. अरे लेंस कवर होने से नहीं होगा इसमें लाइट आता है. तो उसको बंद करो.
Santosh, this is good.
हाँ. This is good actually. This is good. I'll come. We make this half of us.